you don't have my resume. I follow the academic resume pattern, which at Albert Einstein College of Medicine requires that you literally list everything. Every lecture I gave, every grant I wrote, every job I had, every little thing. It's 50 pages long. It's just not worth looking at. But I'll tell you, my first experience in this building was probably in the early 80s. As you know, WIHD is a university center for excellence for persons with developmental disabilities, and a LEND, a Leadership in Education in Neurodevelopmental Disabilities program. They're part of a network of LENDs and USEDs that exists across New York State. There are three, Rochester, WIHD, and Einstein. Each have a LEND and a USED. I ran the LEND, I trained in the LEND and the USED in the mid-80s, and I came back in 2015 to Einstein and Montefiore to run that program. So up until January of this year, I was on the faculty at Einstein, employed at Montefiore, running a LEND and a USED and some other federal training grants, and doing some research and teaching and seeing patients. So this is my first role in state government, worked with many states, 2025, done lots of different things. Started my career as a DSP, spent a lot of time with my brother. My brother has a child who's a client of the service system in New Jersey, so I was there when my brother's son was born because he had many broken bones. And have some first-hand experience of what many of you as parents are going through. I've done, I think, probably more home visits than any commissioner ever, because for 25 years I saw patients and did lots of home visits, beginning in probably 1985 when I was going to the projects in the Bronx, like Castle Hill projects and places like that. So a couple of things that are experiences that are really important to me were the two different boards of directors that I was on for managed care organizations. So I was on the board of a provider-led managed care organization in New Jersey. It's a joint venture between the University of Medicine and Dentistry, the medical school, and University Hospital, which was the largest hospital in the state. It was a provider-led plan, meaning it was run by the providers, the healthcare providers in that system. It ultimately failed and was taken over by a for-profit, publicly traded Medicaid managed care company, and I transitioned from one board to the next. So I have a look at what different managed care organizations look like from the perspective of being both provider-led versus for-profit. So that experience is really valuable to me and does impact the way I look at the world. So I'm just going to kind of provide some broader context to then focus on more detailed issues around the questions that we'll hear. But I just wanted to begin with the budget. For me, the budget kind of defines the scope of what I do as an administrator. You understand I'm in the administration, the executive part of government, not elected, I'm not an appropriator. I receive a budget and I manage to that. And my job is to try to find ways to maximize the effectiveness of the funds that we receive. So we're really looking at three different issues within our delivery system and how we allocate the resources we have. We're looking at access to be certain that people can receive the right services that they need in the right place, at the right time, with the right intensity, and with the right provider. And as I talk later about a continuum of care, of services and supports for people with disabilities and their families, we want to be sure that, in particular, we can provide the right service to families of younger individuals with disabilities, so we can support individuals in their homes for as long as possible. We're also looking at equity. How do we distribute the resources? What's the basis for making decisions about how much, for example, ComHab someone might receive versus someone else? And we're also looking at sustainability. How do we manage the resources we have to support as many people as we can, and to do that over time, given, every year, probably in time of history, people have said, given the budget restraints that we have, whatever they happen to be, whether they're the global economy, the national economy, the unemployment rate, the tax policy, whatever, there are always constraints on resources. We need to look at how we can sustain what we've built and build something that will be sustainable going forward. So as we're thinking and talking about the systems that we're putting into place, whether they're around managed care, waiver, self-direction, housing, keep in mind the North Star for us are issues around access, equity, and sustainability. So the budget for the entire state, about $175 billion. For OPWDD, we receive about $4 billion in state money, which we are fortunate to be able to match because we're in a Medicaid program. We have a waiver. We can take requests to the federal government and receive gross another $4 billion worth of funding, which leaves us about $8 billion to spend on services. Sounds like a lot of money, but think of it as a checking account. The money comes in and the money goes out. We spend $5.1 billion on our housing and residential portfolio. We support 43,000 people in a variety of different certified and non-certified residential settings. That's 60% of our money. So we have 140,000 people we support overall. We have about 107,000 who are in CCOs. It's an increase of 7% from last year where we had only 100. We have a waiver which has right now today a ceiling of about 85,000. For those of you who read the waiver renewal, we bumped that up to 90,000 in the first year of the next cycle. But a disproportionate amount of our money goes to support people in housing, which leaves us less to provide services and supports that people might need or desire to prevent a request for housing. And in particular, in my experience as a clinician, a physician providing primary care and mental health services and managing epilepsy, I know from my experience that we can provide better services at a lower cost point to people in their homes, helping to teach and support families who want to manage challenging behavior, who are having trouble with their children, who don't sleep, who in many ways are exhausted without support. So we have to figure out how we can create a system that matches the needs of people before they get to a point where they have to call the emergency room or go to the emergency room or seek hospitalization and ultimately seek residential services. So we're looking at ways to do that on a systemic basis. I'm not telling any secrets when I tell you that next year's budget environment will be difficult. Some folks have said, you're OPWDD and you're not all the rest of government, so you shouldn't have a problem if everything else is a problem. But that's not the way government works. It's not that, if the Department of Health has a challenge or other Medicaid programs have a challenge, that doesn't affect us. We're all tied together. So if there is a plentiful environment with many resources, we share in that. And if there's an environment which is more challenging, we also share in that. So we expect that we'll have a difficult budget year. We are waiting to receive the guidance that comes to us from the Department of the Budget, and then we'll be able to look at that and go forward with a budget proposal which will be vetted probably in January, February, and then incorporated into the larger state budget negotiations. But again, just to remind you, we're not appropriators, we're administrators. Our job is to take the funds that we receive and try to achieve that three-part goal that I outlined of equity, accessibility, and sustainability. Just to help you understand our budget in the context of other states, one metric I think that's been really helpful to me is to look at the amount of money that's spent in New York on a per capita basis and reflective of the income that individuals received in New York State. So there's a metric called financial effort per $1,000 of income, and that corrects for a lot of factors. If you've got a rich state with folks who have high income, you can then make a comparison between poor states where incomes are generally lower. On average, states spend about $4.41 per $1,000 of income on services for people with developmental disabilities. So, for example, if you earned about $100,000 in a year, about $441 would go from you to the tax base to support people with developmental disabilities. That's the national average. The the amount of money in New York State that goes to support people with developmental disabilities is more than twice that. So $9.06, I'm sorry, of every $1,000 of earned income is spent to support people with intellectual and developmental disabilities. And I guess where that puts us nationally in terms of rank? We're number one by far.
Yeah.
The second state, which is Maine, we spend about $8.02. So we're literally about 12% higher than the next state. And I think that gives you some idea of the relative amount of financial effort put into support people with IDD in our state. Our neighboring states, Connecticut, Pennsylvania, New Jersey. Connecticut, $5.25. Pennsylvania, $5.26. New Jersey, $3.73. Again, the national average about $4.41. That kind of data is available to the public on a website called State of the States. It's operated by the Coleman Institute, University of Colorado, directed by a guy named David Braddock. It's older data, it's from 2013, but believe me, we didn't go from number one to the median in the last 6 years. We are still near the very top in terms of fiscal effort. So for me, the challenge is how do I get the most value from that resource? We have a lot of money. The question is, what do we do with it? How do we support people with it? So then, with that as context, let me go down to some of the topical questions that we're going to receive, just to have some context for them. So, managed care. Managed care is something that's been under consideration in New York State for at least 25 years. And I remember in 1996, I was asked to come to New York and give a presentation at the Cerebral Palsy Annual Conference at the Desmond off of Route 87 up in Colony. So at that point I was working in New Jersey. We were rolling out mandatory managed care for people with disabilities, and I came to share my insights on what was going on in New Jersey. This isn't something that's new, it's something that's been going on for a long time. Probably 2011, 2012, there was a formal proposal for what were called DISCOs, which were the, if I remember, Developmental Disabilities Individual Supports and Services Coordinating Organizations, DISCO. And the thing to remember about DISCOs is it incorporated two systematic changes or structural changes. One for the DIS, which was the delivery system, and one for the CO part of DISCO, which was the care coordination function. Okay, so DISCOs encompassed two separate system changes around two separate functions. How the system was built with the providers and how it was coordinated and managed. It didn't really get off the ground. 2013, 14, it kind of petered out. But the concept was still there, and I think when you think about the new iteration for Medicaid managed care for people with developmental disabilities, it incorporates that same concept of we need to reform the delivery system, we need to reform the care coordination component. So then when you look into like 2015 and 16, and you see that the discussions shifted to focusing on care coordination, then it kind of makes sense. Well, we need one step at a time as opposed to both at the same time. So in 2017, there was a discussion about creating care coordination organizations, entities that would consolidate the functions of the former MSC programs, which was really limited to developing ISPs or care plans for individuals to access the waiver. It changed into a broader concept around health, and the plan became a life plan, and the role of care coordinators changed to incorporate healthcare planning in addition to waiver to try to coordinate those two services. That system launched in July of 2018 with support from the federal government. New York State decided to use the health home option under the Affordable Care Act, which allowed New York to generate 90-10 federal match, increased actually the amount of money that we could invest in care management, and try to develop a better, more comprehensive and integrated system. Things consolidated around 7 organizations now that provide CCO services. I think in this part of the state there are 3, and they have been in operation now for 16 months. You can imagine going from 350 Medicaid Service Coordination Organizations to 7 CCOs was a challenge. The 7 CCOs were new corporations. They did not exist prior to July of 2018. They had 0 revenue, 0 employees, 0 infrastructure. And we asked them to take on the responsibility for managing what had been a $300 million program and is now a $500 million program. And there were growing pains. They had to find an IT vendor. They had to build an IT infrastructure. They had to hire staff. They had to train them to the new model, which was broader, not just the ISP, but incorporated the life plan and incorporated healthcare services along with the waiver. So there were a lot of growing pains. I arrived in January, and after 7 months, 100,000 people were being served. Only 5,000 had life plans at that point. 5%, it's really not very good. So we said to the CCOs, here are the deliverables that we expect. End of the first quarter of 2019, we want 25%, 50% by the end of the second quarter, 75% by the end of the third, and by the end of December 2019, we expect every individual in our system to have a care plan, a simple metric. And we're on our way to achieving that. We're up to about 80-85% depending on the CCO. But that's really not enough, and as many of you know, and I'm sure will tell me later, the quality of those life plans is in many respects lacking. There's been turnover. I can see the thumbs down already. I'm not going to stand here and say that it's been perfect. But we understand. But we're literally moving the goalposts for CCOs. First it was everyone has to have a care plan, and if you can't do that. No, you have to do that, and you have to do that by these dates. And now that we're well on our way to achieving that, we're going back, we're looking at the quality of the care plans, we're looking at staff turnover, we're looking at the more qualitative aspects of the CCO operations. We're also telling the CCOs that this is information that consumers, individuals, families need to have so they can make the best decisions for themselves about who should be doing care planning, who should be supporting them in developing life plans. So we've said don't worry about it, I can go on. When we have the data on the percentage of individuals who have life plans, we're going to put that online. We're going to make that available to people off of our website. And after January 1st, we're going to be putting that information online so you can look at it and see which CCOs have at least provided 100% versus those that haven't. We're also developing a report card style approach to the qualitative aspects of CCO operations. It'll be something simple, 1, 2, 3, 1 star, 2 star, 3 stars, red, yellow, green, which is currently what we're using. It won't be so much like 83.7% or that kind of detail, but it will help people understand that this CCO is doing its job and this CCO isn't, and that this CCO needs to work harder to compete with its peers. So we're using that as a means of encouraging CCOs to perform more effectively. So that's in place, it's operating. We're trying to make that be as effective as it possibly can. The second step, if you think of the DISCO, the CCO part's done, now the delivery system. The second part is the delivery system, the managed care organization, what we now call the SIP-PL, which is the Specialized Individual Plan - Provider-Led. So over the last 6-7 years, there's been a lot of feedback from all of you about what managed care should look like. What's important about managed care and it being successful. And so you told us that you wanted to be informed by organizations that have a history of providing services to people with developmental disabilities. So we created this concept of a provider-led plan. We're not talking about mainstream plans. We're not talking about the for-profits that come from out of state that really don't know our individual history, DD history, but we're trying to create a managed care system with our IDD providers. That is a challenge because our IDD providers provide services. they're not familiar with running insurance companies. They're not insurance executives. And believe me, when you step into that space of trying to run an insurance company, it's unfamiliar and uncharted territory for a lot of our executives. We are working with them and trying to support their capacity in building organizations that can serve as managed care organizations, that can assume financial risk, that have capital reserves, that can help to meet the 3 goals that I outlined of accessibility and equity and sustainability. But that's hard work because this is foreign territory for them. So in August or September of last year, 2018, we published a document called a qualification document, which identified the scope and operations of CIP-PLs. And that information was made available. We received 75 or 80 letters from individuals and organizations. We've been working internally to incorporate that feedback into a revised CIP-PL qualifications document. And that revised document should be made available, I believe, sometime in November. It's very close to being finished. It's being vetted by internal stakeholders, OPWDD, Department of Health, Medicaid, Department of Budget, so that we can ensure that we incorporate the feedback that we receive and give all of you an opportunity to look at it and see what you think. And so my hope is that when that document comes out, you'll be able to examine it in light of what you saw more than a year ago and give us feedback as to whether or not this is the right direction or that's the right how, the right way to do this. So that's an opportunity that's going to present itself shortly. You've also seen that we just published our renewal for the 1915 C waiver. There's a question that's going to come up just to address it. There had been discussions previously, I think in 2017-18, about OPWDD being aligned with the larger 1115 waiver that was being submitted by the Department of Health. My understanding is that's no longer a direction that's being pursued, that we, OPWDD, will continue with a separate and independent 1915C authority for our waiver. What that does is it gives us a little bit more flexibility, which I think is a good thing. It will give us an opportunity in the future to be able to tailor our system in the way it's designed to meet our needs a little bit more effectively. Is there a question? I can't hear you, I'm sorry.
What's a C waiver?
1915 has lots of flavors of waivers. There's an A, B, and a C, and I think C is for the home and community-based waiver for the IDD services, if I'm correct. I'm not great on the technical aspects of the waiver, but to me they're just tools that we use to shape the system that we build. Okay, so just a couple more points. As I've described it to you, OPWDD is a large organization. To me, it's almost in some respects a business designed to provide services. So I told you we have a budget, and now I'll tell you we've got 2 separate parts of our system. We have the regional offices that manage our relationship with the voluntary contractors, the nonprofits. About 80% of our resources are spent with the voluntary organizations. About 20% are spent in support of state employees who deliver services also. So of the, for example, 37,000 certified residential opportunities that we provide, 30,000 are provided through voluntaries, 7,000 are actually provided through state employees. So about 20% of our delivery system is through the state operations. We also have a management function. Our job is to look at things like eligibility and allocating resources, looking at how we employ staff and deploy those personnel to support our goals. And I'll try to be charitable about this, but I think because most of our focus has been on trying to roll out a managed care program over the last 7-8 years, less attention has been paid to how we operate internally. So when I put on my my management hat. I did pick up a management degree along the way. And I think of my time on the board of a provider-led plan, or on the board of a for-profit managed care plan, or an entrepreneur in starting businesses in New York, New Jersey, and Arkansas, or my role on nonprofit boards. You know, there are management issues that organizations of any size have to have in place. Things like budget control, personnel control, aligning strategy with policies and procedures. And I think in general, OPWDD had neglected in some aspects to build that kind of management infrastructure. So for example, right now with our care planning process, we work with, at sort of arm's length, the CCOs and the care coordinators in developing life plans. So when you all work with a care coordinator, you sit down and you look at the needs of your individual, and you work with the care coordinator to develop a life plan. That life plan then comes to the regional office, usually, and it's approved. And then you go back out and you work with service providers, whatever capacity, whether they're residential or self-direction or other types of modalities. And 6 months later, OPWDD finds out that the services that were authorized through our regional office have resulted in this much cost. We don't have a point of control at the process when it begins. And so we find out later that we've obligated and spent X amount of money. And given the way things work, it's usually more money that's been obligated and spent than we had anticipated. And that creates a challenge in then how do you stay on budget? And the easiest way for us to stay on budget is to go back to our providers and say, you know, we can't pay for an increase, or we have to find efficiencies or cuts or rejigger some of the program funding. So it's not proactive, it's reactive. What we are working in developing is a proactive model of program planning, which ensures that we can allocate the resources to meet that three-part goal that I talked about: accessibility, equity, and sustainability, but prospectively, so that we don't come back to providers 6 months later and say, we have nowhere else to turn but to you and to take it out of your rates. Because I know that many of you are concerned about provider viability, about whether providers have the resources they need to support your loved ones, and we do too. We think the best thing to do is to help create an environment and structure that allows them to plan going forward, rather than to keep looking over their shoulder, is OPWDD going to come back and cut my rates next year? So we're trying to inject the budget component, the fiscal component, into the care planning process at the very beginning, so we all have a common understanding of how much resource we can allocate and then where we will land at the end of the fiscal year. One thing that we can do, and a tool that we have not used historically, is our acuity measurement. So you know that we have something called the DDP2, which is used to help understand the needs of individuals. We're moving towards the CAS, the Coordinated Assessment System, which is used to assess the needs of individuals. We think we can use something like the CAS, which is scientifically validated, developed by a third party, to help predict what amount of resource we as a system need to allocate to support people, and then allocate that across large numbers of people across a tiered system. So for example, the CAS will help us understand if someone has low needs or high needs. And based on just that simple understanding, we can allocate lesser resources to people who have low needs and greater resources to people with high needs. Going forward, that's extremely valuable to us in being able to ensure that we meet that three-part mission and we're all moving along with the same set of expectations. Again, we're looking at how we can insert fiscal control and base that on an equitable allocation through the CAS. We are also looking at personnel control so that our system matches up with needs. Right now, we just kind of iterate. So let's say, for example, we had 8 mechanics and 1 retired. We'd go out and fill the 8th mechanic position. Whereas we might really need someone who's in data or quality improvement who can help us understand where our system is going. position control allows us to look at every vacancy, every opportunity to fill a position and make sure that it maximizes the value to our system. So we're looking at building that. And we're also looking at standardizing operating policies and procedures across our system. I'm not sure how many of you are in Region 4, most of you are probably in Region 3, but there are differences between the ways Region 3 and 4 operate based on the fact that we don't have centralized policies and procedures. So there are different answers that families may receive from one regional office to another, and we're working to standardize that so that you get a consistent response from each regional office. We're also looking at programmatic centralization, so things like the START program, which is a crisis response program that does exist in both Regions 3 and 4. We want to standardize policies and procedures and intake so that we know when people are in crisis, and we can go back to our contractors and ensure that they are interacting and supporting those individuals as soon as notice is given. Right now, our providers are that interface, and if they respond to the family, great, and if they don't, that's not good, but we don't know because we don't aggregate that data. So one simple step is we create a single point of entry, an 800 number for crisis response services statewide. We can identify who the individual is, when the referral came in, and make that referral back out to our crisis response contractors. And the clock is running, and we're going back then and looking at making sure that they provided a timely response. So we're trying to look for ways to identify variation and eliminate it when it's not really helpful. Give us some better insight into how our system operates. Again, ensuring that we meet that three-part goal, being equitable, providing access, and making sure that we're sustainable. So those are the kind of like the high-level things. Some of the questions now, there's a context that we provide to be able to understand how they fit. So happy to answer the specific questions, and to be honest, I'm pretty comfortable if you are with folks raising their hands saying I didn't understand that or I want more detail. So you're in charge of the clock and the audience. So whichever way you want to go, I'm flexible.